And welcome to this week's Grand Rounds. Before we start, I'd just like to acknowledge the traditional custodians of the lands on which we meet, the Ngunnawal people, and pay my respects to their elders past, present and emerging. And I'd particularly like to welcome any First Nations people here with us today. We're very fortunate to have someone who needs no introduction to this audience, Vipul Aggarwal, who is the Director of Gastroenterology and Hepatology at Canberra Health Services and has a particular interest and expertise in interventional endoscopy and its role in pancreatic-biliary and GI malignancy. He's also the current, amongst other things, the current chair of the Faculty of Australian Endoscopy. And he's going to talk to us today about a very interesting and challenging topic, endoscopic bariatric therapies, challenges and breakthroughs. All
right, thank you. Thanks, Tim, for that kind introduction. And I'm glad you're chairing this session, because I think any questions that are technical, and as a technician, I'll answer those. Anything that's to be, more scientific, I'm sure you'll be able to respond to those ones. So I chose this topic, endoscopic bariatric therapies, because obviously it's an area of interest for me and some of the interventional gastroenterologists, but it is a bit like an elephant in the room that we know about it, but no one really wants to talk about it for various reasons. And that might become a little bit more obvious in terms as to why. And for some good reasons, but maybe there is an opportunity to introduce this particular modality to the wider audience and then go from there. So we all know that obesity is a big problem. There's a global epidemic as far as obesity is concerned. There's more than 350 million people worldwide who by WHO classification are obese. And in the Western world, about 500,000 people every year, their deaths are linked to obesity. And in the last couple of decades, the incidence of obesity has increased by more than 800%. And we're well aware that it's not just about obesity in terms of the weight, but its association with other sort of metabolic disorders such as type 2 diabetes, hypertension, sleep apnea, and non-alcoholic steatohepatitis or cirrhosis is also well established. So what about in Australia? So the estimates are that by 2025, 80% of the population in Australia would be obese or overweight. And this has a significant, if for nothing else, an economic burden with a direct cost of about $8 billion or up to $58 billion in terms of indirect total overall economic burden on the nation. So it is a problem that we do need to think about. Probably this slide should have come before, but this is 10 years old. But if you look at in the middle of the thing in the orange bar and New Zealand above that, they have the highest increase in prevalence, if you like, of obesity, even greater than some of the Pacific Islands. So certainly we're not doing very well in this particular area. But obesity is complex, and not just in terms of why people become obese. It's not just eating more and exercising less. Obviously, there's a whole bunch of hormonal, neuronal, and psychosocial factors that are involved in this, and that is one of the reasons why management of obesity is equally challenging. So it's not just about weight. We know obesity is linked to a whole different medical conditions and disorders. And targeting obesity as a chronic condition is probably going to be beneficial in many ways. But this is a reality in some ways. We know that lifestyle modification and changes will work, but the majority of people want something which would fix the problem without really having to work too hard for it. And therein lies some of the problem, although there's more to it. So lifestyle interventions is always the first line of management, if you like, for obesity, but do they really work? And what are our options? So there's diet and exercise, either in a sort of a more structured manner or somewhat go with the flow. There are some proprietary weight loss programs, Jenny Craig, the ketone diet, there's a few others. And there's pharmacotherapy. Now, I'm not going to talk much about a lot of these, and particularly pharmacotherapy, because that's a talk on its own, and I'm highly intimidated by Tim sitting there right in the first row and to talk about that. But it is an emerging area, and I think in the next 5 to 7 years we'll see more and more medications or pharmacotherapy playing a bigger role. But what is currently available, only 10 to 20% of patients achieve about a 10% total body weight loss, which is needed to improve some of these comorbidities. And that's a key in terms of managing obesity, is how it impacts these other comorbidities. So what about bariatric surgery? I think bariatric surgery is well established. It's got the runs on the board. It is very effective. There's no question about it. And you can get up to 70% excess body weight loss at 1 year. And there's also good data to support that it does result in an improvement in various comorbidities, particularly in diabetes. But the issue with bariatric surgery is this whole concept of hidden obesity, because there's only a small proportion of patients who are suitable to have bariatric surgery actually undergo bariatric surgery, and the majority of up to 99% of the population does not go through with this procedure. And there's several reasons for that. There's cost and acceptance is an issue. There are some real and perceived risks with the surgical procedures that deters them. So overall, less than 1% of patients who would actually fit the criteria to have bariatric surgery really go through with the procedure. So this results in what I would say there's a gap between what your lifestyle interventions and, if you want to call metabolic surgery, your standard of care. So there's a gap which needs to be recognized and probably filled. So theoretically, endoscopic bariatric and metabolic therapies, if it was to be part of the algorithm, you would think it has to be less invasive, more acceptable for patients. And it should not deter either physiologically or anatomically other subsequent procedures such as surgery. And I think the real progress was made in America when the American Society of GI Endoscopy came together with the American Society for Metabolic and Bariatric Surgery. And I think that's part of the challenge when there's two different societies involved, and if they don't come together, you're probably not going to get the outcome. But in 2011, they decided to join hands and see if there was a pathway for endoscopic bariatrics to be and metabolic therapies to be included in the algorithm. And then finally, in 2015, they came up with this PV statement, which is PV is basically preservation and incorporation of valuable endoscopic innovation. And they put together a statement whereby endoscopic bariatric and metabolic therapies would be included in the algorithm as long as they met certain criteria. And that would be that they should have a minimum of 25% excess body weight loss at 12 months. And the difference between the endoscopic treatment and control group should be at least 15%. And then greater than 5% of the total body weight loss, which is different from excess body weight loss for non-primary endoscopic bariatric treatment. That is, if it was used to reduce risk of subsequent surgery, so as a bridge to bariatric surgery, or used for metabolic therapy, then the criteria changes to 5% total body weight loss, and the overall adverse events rate should be less than 5%. They put another caveat that if low-risk endoscopic bariatric therapies impact comorbidities significantly, then the threshold should extend to class 1 obesity, which is patients with BMI of between 30 and 35. So what are our options? And there's multiple ways that you can look at the options. You can divide it into the part of the GI tract that you target. So you can have gastric procedures, or you can target the small bowel. But the other way of looking at it is what you have. So you have space occupying devices, which are primarily balloons, and I'll talk briefly about those. And then you have the gastroplasty procedures on one end. And then for the small bowel, there's small bowel diversion, gastric aspiration device, and then mucosal resurfacing, which is still not mainstream, but more sort of in clinical trials. But I'll touch briefly on some of those. So intragastric balloons, there's a whole heap of them available, or there's at least 5 or 6 which are approved by the FDA, and at least 3 which are approved in Australia. The majority of these balloons do need to be placed endoscopically, other than there is one balloon called the Ellipse, which can be swallowed, but the data on that in terms of its efficacy is still not widely available. So I'll talk primarily about the Obera simply because that has the most data that's available. And this particular study they looked at, there was a total body weight loss of, so the number of patients who achieved a total body weight loss of 5, 10, and 15% was 88, 62, and 31% respectively. And they did maintain the weight loss up until 18 months. But the main issue with balloons is weight recidivism. So they will regain weight once the balloon has been taken out. The majority of the balloons are left in place for about 6 months, but some of the newer balloons, you can leave them for 12 months. And it's kind of an opportunity for patients to really modify their lifestyle, failing which weight loss is real. Let's see if this video will not play, will it? That's a shame. No? All right. Well, that's 30% of my talk because there are a few videos in there, so that's okay. All right. So insertion of in the Obera balloon or the concept or as a procedure, they're all about the same. It's done endoscopically. You don't need to be intubated, but you do need deep sedation. And essentially it comes as a rolled up, it's a catheter with the balloon rolled up in the end, and you insert it like you would an orogastric tube. We do it under direct vision with a gastroscope. You push it down into the stomach and you follow it with a gastroscope under direct vision. Once it's inside the stomach, you put in about somewhere between, depending on the person and what degree of weight loss and their weight, you put in between 350 to 700 mils of normal saline with some methylene blue in it. And the methylene blue is essentially if the balloon leaks or ruptures, then you can see it in the urine, and that's an indicator that you need to go and retrieve it, because the balloon ruptures, it can cause small bowel obstruction if it passes through. So in some ways, if these patients tell you they're passing blue urine, you need to get them in hospital and extract the balloon. The balloons, like I said, mostly can be left in for about 6 months. There are some absolute contraindications. If you've got a very large hiatus hernia, you've got active peptic ulcer disease, active H. pylori infection, or concerns for significant endosomoplasia, strong family history of gastric cancer, you just got to do a very careful check gastroscopy before you put this in. The main side effects, if you like, are in the first 1 or 2 weeks, like most of these bariatric treatments, which is significant nausea, which can be managed with medical therapy, and they really can't eat much, which is kind of the idea. But in terms of serious complication, it can cause pressure necrosis, ulcers in the antrum, and like I said, if it does burst or rupture and passes through small bowel obstruction, even with that rupture, it can occasionally cause a gastric outlet obstruction with sort of a ball valve mechanism of it. So you always leave the balloon in the fundus, but it can move towards the gastric antrum and then cause, which is a medical emergency. So people need to be able to recognize that. Enough said about balloons. So move on to endoscopic sleeve gastroplasty, which I think is a real deal. It does restrict gastric volume, but that's not the only mechanism. We believe it also alters the gastric motility, and therefore impacts satiety and has a positive impact on weight loss. But you've got to remember, it is a surgical procedure that we're doing endoscopically. So it is a complex procedure which does require a good amount of pre-existing endoscopic experience and then specific training. It's still a relatively new procedure, and the the techniques are evolving. There's no one uniform technique that we think is applicable throughout the world. So there is you know, the basic technique is the same, but suturing pattern and a few other things that unfortunately I can't probably show you on the video today. Currently, in terms of endoscopic sleeve gastroplasty, there are 3 platforms that are available. But there's only one which is available in Australia, which is the Apollo overstitch thing, and across the globe, most of the data is with this particular system. It's actually quite a cool device, and it's a sewing machine, if you like, which is attached over the scope. So if you this is the attachment, which is, and you need a dual channel, so 2-channel, what we call a therapeutic gastroscope. It has wider accessory channels, and you attach this part of the apparatus is fixed onto the shaft or the handle of the scope, and this is the end, which is at the end of the actual scope. This particular, I'll have fortunately go through the theory because I don't think videos will play. All right, that's okay. So essentially what is done is, this is the attachment at the end of your gastroscope, if you like. The patient in this case doesn't need a GEHU, so they're intubated, and quite often they will need what's called an overtube, which is placed, you know, from the mouth into the esophagus to protect the esophagus from any damage from this, from what is attached at the end of this end of the scope. What you see here is like a corkscrew thing. We call it the helix. And once we are inside the gastric, once we're inside the stomach, you push the helix into the gastric wall and use a corkscrew mechanism, attach it to that, and pull the gastric mucosa towards the needle. Once you've got the mucosa sort of somewhere in between that area, you close this needle, which is a full thickness graft, which is a full thickness bite. So if you actually do the laparoscopy at the same time, you should be able to see the suture outside the stomach. Because if it's only a mucosal suture, it's not going to last, and it'll just, you know, sort of. So you do need full thickness sutures. So the different suturing patterns, you start at the antrum, and when we leave the fundus alone, and that's a key difference between sleeve gastrectomies and endoscopic sleeve gastroplasties, that we do not touch the fundus. We think it's a tiger territory, lots of blood vessels and things, and we don't know what we're going through and what we're going to grab with this needle when it travels outside the stomach. So we leave that area alone. Before we do this, at times we will try and create we either do something called argon plasma coagulation or EMRs, because what you want is mucosal to mucosal apposition and not serosal apposition. Serosal apposition will not last. It's a bit, unfortunately, it's becoming a bit theoretical out here because I can't demonstrate it to you on the video. So bear with me for that. Yeah, actually, that one worked. Something happened.
The other one.
No, I got a glimpse. So Saurabh's name in there, so. There you go. Yep. So anyone got any ideas? No? So, what did I press? I pressed something and it works, and then it doesn't. What did you do? Yeah. All right. So this is just, again, you know, a demonstration of that technique that I just taken theoretically. So this is just doing what we call strip endoscopic mucosal resection, or EMR, and that is primarily to promote to promote tissue apposition or at a mucosal level rather than a serosal level. I can't fast forward this, but anyway. So this is the helix that I was talking about. So you basically grab it, you pull the mucosa right in, and then you take a bite with the needle and leave that suture. And then you continue to do this sequentially, starting off, like I said, from the antrum. It does require a fair amount of technical skill to do this. There's a lot of manipulation of the scope and the device within the stomach. And there is, as you would know, a learning curve. I think when you started off, it took about 2.5 to 3 hours to do one, but eventually you can do this in about 45 minutes to an hour. I'm just going to quickly see if you can get to the end result. Yes, and if you think about it, it is an effect that you would also see with sleeve gastrectomies, and you leave the fundus alone. I'm not going to show this again. It was very similar, just a slightly different technique. So can move on. So this study was a meta-analysis of about 1,800 patients, which showed a total body weight loss of 15% and an excess body weight loss of 57% using this, and the results were maintained for up to a 12-month period. But the most of these studies were retrospective and with limited long-term data. But last year there was the first randomized multi-center prospective study, which is a crossover trial in 9 centers in America, which finally gives us which gives us some data from a randomized study. So they randomized 209 patients with class 1 and class 2 obesity to either lifestyle modification along with endoscopic sleeve gastroplasty or lifestyle modification alone. And then the primary endpoint was the total excess body weight loss and total body weight loss at 52 weeks. And as you can see, the excess body weight loss was 49% in the ESG group compared to 3% in the controls. And the total body weight loss was also significantly different. And the secondary endpoint was the proportion of patients who met the PV criteria. And once again, that was significantly greater in patients who were in the ESG group. This was interesting because they also had, as their secondary endpoints, they looked at some of the metabolic aspects or improvement. And there was certainly a significant improvement in diabetes and hypertension and the overall metabolic syndrome. There did not appear to be a significant improvement in hyperlipidemia. And this would be consistent with what we see in some of the other studies out there. The other interesting bit in this study was at 52 weeks, at 1 year, they crossed over the patients. So anyone who was on a lifestyle modification could go onto the ESG arm. And they were able to achieve the same result once they did have the sleeve gastroplasty. The graph on your right is the side effects or adverse events, and as you can see, the majority were mild and usually in the first week. It was pretty well tolerated once you get beyond the 4-week mark. As I said, I won't talk much about the other two, endoscopic platforms because they're not available in Australia, and the numbers in those studies are pretty small. They're more like pilot studies of very few patients. What about the mechanisms? So like I said, we're not entirely sure what all the mechanisms are, but the basic thing is that it's not just volume reduction of the stomach, but actually impacting the motility. So it actually slows the stomach down. So you have more than 50% or 50% solid gastric emptying time is increased in the first 90 minutes. Or in other words, if you did not have this, you would have only 5% of your solid meal left in your stomach at 4 hours, whereas after sleeve, you have about 30% of your solid meal left over in the stomach, which has an impact on satiety. So what they noticed was that there's earlier termination of the meal. So there's a standardized meals that patients got, whether they were in the lifestyle modification arm and the other arm, and they stopped eating at about 11 minutes as compared to 35 minutes in the other group. So moving on from what else there is data to support its role in other metabolic syndromes. So this was a study of 118 patients with obesity and NAFLD, or non-alcoholic fatty liver disease, and they had a 2-year follow-up, and the results were quite impressive when you look at it, where the improvement in the insulin resistance was significant, as was in the hepatic steatosis and the index and the fibrosis score. So it is the benefits of any of these procedures, be it surgical or endoscopic, are going to go beyond just cosmetic weight loss. Now this is where Tim comes into play. I just put it out there that the multiple hormones that impact the whole concept of obesity, and you would think intuitively, so ghrelin is a hunger hormone, so it should go up when you're hungry and you eat less, and it is produced from the fundus, and that's where the surgeons would argue that this procedure should not work for this pathway. But studies have looked at, even though you don't get a reduction in ghrelin, you don't get a rebound rise either. There are other pathways. The GLP-1 are well known because of all the new pharmacotherapeutic medications. Weight loss medications are based on some of those pathways. And then leptin and adiponectin are probably the other gut hormones that are impacted by these procedures. Yeah, this is just what I was talking about, the difference between the sleeve and the fundus. But essentially, these are the various hormones, gut hormones, that they've looked at, and like I said, surprisingly, no increase in ghrelin and no decrease in GLP-1. But the leptin and insulin changes are matched. So I think one of the errors that the initial studies did when they looked at ESGs was to try and compare it to laparoscopic sleeve gastrectomy, and it's not a direct comparison to that. Your standard of care, what you should be comparing any of these modalities is to your lifestyle modification and not with sleeve. Having said that, it's not surprising that this study compared the two, that the total body weight loss at 6 months was significantly greater with sleeve, but it did have higher adverse events, particularly when you look at gastroesophageal reflux disease, which is a well-known adverse event, if you like, with sleeve gastrectomy, but not so much with an endoscopic procedure. I'll touch on a couple of other endoscopic modalities. There's something called the aspiration therapy, or the Aspire Assist system. Believe it or not, this is approved by the FDA. And what it is a very large bore peg tube, essentially, that is inserted endoscopically into your stomach. And patients are taught how to eat. They need to chew their food well. There's certain things that they can't eat. But generally 30 to 45 minutes after they've eaten, you can either have a suction bottle, or you can go to the toilet and you essentially open the tap and you let things out, a bit like the Romans used to do, I suppose. It does work, and the argument for it was it gives the patient control. It's a very American concept, right? So the patient is in control. They can choose what they want to eat. They can, open the tap what they want to do. So no one needs to tell them what to do, and that's a very American concept. But if you look at the data, it does work. It's just an interesting concept in some regards. So it is certainly available. Health funds pay for this in the US. And just finally, just a couple of other methods. So the one is duodenal mucosal resurfacing, and this does not result in a significant weight loss, but there's certainly very good data to support that in diabetes. So it results in a pretty good reduction in HbA1c. And what it uses is a balloon that uses thermal hot water through the balloon, which burns the mucosal surface, about 20 or so centimeters, 12 centimeters of the duodenum. And and that's the mechanism in terms of absorption. But this is still not, a randomized controlled trial has completed recruiting, but we're waiting for the results of that. Again, it's a very American concept. The endoluminal diversion technique, sorry for the typo there, but this was actually pretty good. I have used this endobarrier device, which was a very simple device. What it was, a polyurethane tube, essentially 60 centimeter tube with an anchoring device, which you anchored in the duodenal bulb, and you just let the tube flow. And what it did was it reduced the absorption from your proximal small bowel. It was extremely effective. And certainly, again, in the metabolic area, but there were some significant side effects, particularly there were a few hepatic abscesses, so the study was terminated early. Few research priorities and unmet needs are coming towards the end of the thing. So there are some we need to assess long-term efficacy results and thresholds. I need to define more clearly the inclusion criteria for the use of endoscopic bariatric and metabolic treatments. We need to determine whether they have a positive impact on clinically meaningful outcomes and not just weight loss. You need some trials between different modalities, and we need to further understand the mechanism of action. But like I said at the start, it is a complex procedure, and who should and who shouldn't do it, what sort of training program you should have. And the ESGE, which is the European Society of GI Endoscopy, has come out with a few suggestions. So they recommend that any endoscopist who wants to do these procedures should be competent in upper gastrointestinal endoscopy before embarking on training for these. And then the trainees in bariatric endoscopy, they should understand the complication of bariatric surgery, should have basic knowledge about the classification and social impacts of obesity and its pathophysiology. I think, like anything else, it is important that this is not done in isolation. You always want to do this as part of a multidisciplinary team, which includes surgeons, it includes your dietitians and nutritionists, your psychologists, and the decision should be made together and to just be part of the algorithm and not do this on your own. And there should be a better training program. So there is no formalized training program. I went to the States they have a course that you can do and then the industry runs some of these courses. And once you've done that, you progress from models to animal models and then to humans. Proctorship is important, so you always should have someone who's got a lot of experience in this to come and supervise probably about your first 5 cases. So in summary, I think endobariatric therapy should be considered in patients who are unable to lose weight or maintain their weight loss with other interventions such as lifestyle. It can be used as a bridge to bariatric or other surgery, remembering that it does not preclude to further surgery if it is required. And like I said before, it should only be used as part of a structured weight loss program. Medical and psychosocial comorbidities contributing to obesity should be addressed or should be part of the discussion. And the clinicians should be aware of the risks and receive comprehensive training before embarking on any of these therapies. Yeah, thank you.
Well, thank you very much, Vipul, for a comprehensive discussion of what is a relatively new and exciting technique to address a chronic problem. I'll take the chair's prerogative to ask the first question. One of the major issues, as you know, for those of us who deal with obesity medically is the lack of access to effective therapy, no PBS funded pharmacotherapy, for example, and a limited resource for laparoscopic sleeve gastrectomies for patients of the OMS. Are you proposing, or have we started training gastroenterologists in these endoscopic bariatric techniques? And is there going to be a role at Canberra Health Services for the
I think you said exactly what the issues are out there. It is in terms of the primary issue is currently is fully self-funded. So there is no Medicare item number for, say, for example, the sleeve. So they are self-funded and they're expensive. You know, it's going to cost a patient about $12,000 to have this procedure because just the device is about $5,000. It did have an item number, and I'm just looking at any surgeon in the room. It did have an item number initially when it came through, but that was controversially taken away. So at present, that is probably the biggest limitation. Unless they are fully self-funded, health funds don't pay for it, and so the patient has to self-fund that. But there is a submission is in process. A lot of the submission, to be honest, comes through industry, and a bigger company has taken over this particular product, which we think it's not just I mean, it is a suturing device. It's used in many other areas for perforations and all of those things. So there is a submission that's expected to be made in the next 6 months or so, and then we'll wait for the outcome. And I think that's going to be the key in its uptake.
Will that also be important in driving training?
Absolutely. So this is what we did. We started all this process a few years ago, and there were courses and there were training, and we did a few of live courses also, but then it all stopped once the item number was taken away because the interest dropped and the number of patients that could undergo this procedure significantly reduced for that reason.
Yeah. Thank you. Questions from the thought? Yes.
Really, do you believe that if you talk about the typical gastroenterologist or the answer of the cancer surgeons, it is more complicated than what?
Yes, it is a complex procedure, and I think it's very important that not everyone embarks on this. And that's like any other procedure. I mean, the bariatric surgery is the same. I mean, sleeve, you know, you need to have an interest in that. You need to be part of a team. You need to go through that training. We do believe that you need to have you should be on the, it's relative, but on the higher end of your technical skills as far as endoscopy is concerned. So if you don't do enough endoscopy, if you don't do complex interventional endoscopy, then this procedure could be quite challenging. And I think it's not just doing the procedure, but it's dealing with your complications, which is equally important. So the more complex endoscopy you do, you're more likely to have come across those complications that you learn to manage. So that's part of the thing. So we think people who do other interventional endoscopy and not just gastroscopy, colonoscopies are the ones who should initially get into this. Yeah.
Yes.
Do you think that? Okay. Do you think that the definition of what's obese and overweight should move away from BMI into like?
Yeah. So it's a good question, isn't it? Because BMIs don't take into account your ethnicity, and they're not sort of, you know, have never accounted for any of those other factors. So it is a rough estimate of that, and I think Tim might be able to answer that better.
No, that certainly the use of waist circumference is because of what Vipul has said, the inaccuracies associated with BMI and the ethnic dependence on of the BMI. So people are now focusing much more on waist circumference in lieu of body composition studies.
Got some questions in the chat.
Okay, a couple of questions in chat. Unfortunately, I haven't yet picked up my glasses, so you're going.
I'll try and read that.
If you can read that.
I think the question is, in terms of the role of these techniques as a potential bridge to metabolic bariatric surgery, are there limitations in regard to BMI for these techniques? Yeah, so the limitation is not in the technique. So you can do this procedure irrespective of the BMI. It's about what results are you going to get. So you have to be realistic. The patient has to be realistic in their expectation with any of these endoscopic bariatric therapies. If you're going to get a balloon, you're going to get this degree of weight loss. And if you're going to have a sleeve, endoscopic sleeve, it's never going to be the same as a laparoscopic sleeve gastrectomy as far as weight loss is concerned. But it's important to remember that that does not mean that you cannot, if you had regained weight or did not get the desired result, you can still undergo surgery. The way that we place these sutures are along the greater curve and it does not impact surgery. So the surgeon's concern is if the sutures are left behind and they went and did a sleeve gastrectomy, there's going to be a leak, so because they're not going to be getting a clear staple line. But that's the portion of the stomach that actually is going to be coming out in their gastrectomy. So if the procedure, the sleeve is done properly, the endoscopic sleeve is done properly, it should not impact their ability to have further surgery.
One more question there.
Maybe a controversial question for Tim, and apologies to me. Now that pharmacotherapies are emerging with total body weight approaching 20% at 1 year, do you still think there will be a role for these resource-intense procedures in the future? And I think we
so as people know, obviously the GLP-1 agonists, the twin cretin tirzepatide's about to be launched in Australia, and more effectively is retatrutide, which is the triple G agonist, glucagon, GIP, and GLP-1, which 1 year phase 2 clinical trial data was published last week or 2 weeks ago in the New England Journal, showing sort of 22 to 25% 12-month weight or 48-week weight loss. I think that data is still in its infancy, and we will need longer term follow-up data for efficacy, and amelioration of aspects of the metabolic syndrome that Vipul has shown. I think with all of these techniques, as Vipul has illustrated, we will need longer term data before we have and particularly data on cardiovascular outcome as the consequences of obesity before we know exactly where these interventions are placed.
And I think it goes back to it is a complex condition, and I don't think it's going to be a one size fits all.
Yeah.
So you're not going to have a single modality that's going to be applicable to the entire cohort of patients who need that, be it for the weight or be it for the other comorbidities. So there's going to be a selection of, if you've got a BMI of 50, no pharmacotherapy or no endoscopic treatment is going to work to the degree that's needed for that. So there's going to be these other, so I think it's always, again, going to be a multimodality, multidisciplinary approach and careful patient selection for each of these modalities, whether it's pharmacotherapy, endoscopic, or surgical. And that would be the way to approach the whole condition here.
All right. If there are no further questions, just remains to thank Vipul again for a fantastic overview and